before we get started, maybe we could just do a quick round of introductions, so your name and affiliation for everyone in case folks aren't familiar in advance. So Representative Cunningham, do you want to kick it off?
Yeah, I guess I can. I'm Representative Cunningham. I represent District 106 in Mecklenburg County. I'm also a 35-year nurse that served hands-on. I wasn't in an office. I've always been hands-on. I'm glad to work with you all and see so many of you taking up this issue. So thank you for having me. Thank you.
Great, thanks. And Dr. Moncad, I'm going around my Zoom screen.
Okay, great. Mehul Moncad. I'm a psychiatrist by background. Right now, I'm the Chief Medical Officer for one of the LME MCOs, which are the Medicaid managed care organizations in the state of North Carolina. Mine serves the Triangle and Cumberland County, Fayetteville area. I do also have 16 years of experience at the VA prior to the role that I'm in. So if you have questions about kind of single payer or that style of healthcare, I have that background.
Excellent, thanks. And Chip?
Chip Baggett, I'm CEO and Executive Vice President of the North Carolina Medical Society.
Lisa?
Hey everybody, I'm Lisa Macon-Harrison. I'm a local health director at Granville and Vance Public Health, a two-county health district in a rural area, busy giving vaccines today down the hallway. Glad to be part of this conversation still, because it's so important for us to figure out how to envision what the future of public health looks like and what that looks like in lockstep with new ways of covering people's ability to access care. So grateful to be here.
Thanks, Lisa. Dr. Newton?
Yeah, I'm Tommy Newton. I'm a family physician, a private practice family physician in Clinton, North Carolina, and Sampson County. Been here for practice for 37 years. I'm representing the NCCHCC and all family physicians.
Excellent, thanks. Emma?
I'm Emma Sando. I'm the Associate Director of Strategy and Planning at North Carolina Medicaid. I'm not part of the council, here to listen, and also I'm speedy with getting answers to questions on Google. So if anyone has any, I'm happy to perform that task for everyone.
And finally, I see Christopher, and the last name is cut off. I'm not sure if that's Senator Jackson.
Yeah, I apologize. This is Christopher Stock from Senator Brent Jackson's office. Senator Jackson couldn't be here today, so I figured I'd step in for him and make sure I got the information and was here for all the discussion. So
Great. Well, thank you for being here. Okay. I'm going to go ahead and share my screen. Any questions or before we dive in here on the principles themselves? Can you all see that okay?
Yeah.
Yep. Okay, great.
Yep.
Can you make it just a tad
Yes.
larger, Rebecca, actually?
A little larger, sure.
Yeah, that'd be helpful.
How's that?
Even with my old lady glasses, that's helpful. Thank you.
Sure, yeah.
I
Okay.
actually printed mine out, so I have mine in front of me.
All right. Even better. Well, great. So we can, I will let you all kind of drive this a bit, but I can open it up with just kind of what were your first reactions to the straw man principles. We can go through kind of the big bucket items and say, does these make sense? Are there ones that you would want to take out? Are there other ones you'd want to add?
Yeah, I'll kick it off, Rebecca, if you don't mind.
Sure.
When I looked over these this week, there are three that stood out to me as real principles, and the others seemed like effects that would happen as a result of us doing work. Mm-hmm. So access to coverage, affordability of coverage, and efficient use of taxpayer dollars. Those seem to be like real principle pieces of how we should kind of come up with a solution. And then the benefits of doing those three things seem to be the health system sustainability, supporting business communities, supporting rural communities, all those, expanding other coverage or reducing disparities. So that's just kind of how I read it. And I don't mean to be critical. I appreciate you giving us something to react to, because starting with a blank piece of paper today would have been pretty grueling. But that was, I just kind of distinguished three of these as principles and the rest as more like benefits.
Hey, Chip, just a clarification as I'm kind of parsing the individual words. So so that we're all on the same page. In this case, affordability sounds like it's kind of based at the level of the individual, whereas obviously efficient use of or stewardship of taxpayer dollars is at a more macro level. So that is, you know, even though both of those have to do with cost, it sounds like the contributions come from different angles. Is that how we all agree to see this?
This is Representative Cunningham. Excuse me. I think Chip is onto something about those three items. But also I think that if we could look at each one of them and kind of prioritize and sort of separate them out and see which group or which items are priority and which ones that can come second and which ones can come third if we can get to number one. That's how I kind of think about it, is prioritizing what maybe it's 3 or 4 things that need to be in that one that's top priority, so that we can tackle them as trying to reach the goal. You know, like he's saying, it's several interventions, as I would look at them. Interventions are several things that we want to get to, but it's always 3 or 4 that we need to get to first before we can move on to the other ones. Does that make sense?
Yeah, and if I before I'm happy to kind of apply that structure to the conversation, Representative Cunningham. I did forget to clarify before we started. Is there someone who would be willing to report back to the full group when our breakout is over? What we'll do, I believe, when we go back to the full group is then when it's our turn to report out, I'll pull up my notes here that I'm taking now. So you will have this to speak from. Would somebody be willing to do that report out for us? You will all be great.
I have a history of deferring to the elected officials in the room. So
you're on mute, Representative.
No, I think Chip should do it. I may have to get up and walk around some, so that's why I've been going in and out. I have to get up and move. So Chip, I think you'd be great at it. Thank you.
yes, ma'am.
All right, thanks, Chip. Okay, and then so applying Representative Cunningham, your approach here, are you suggesting looking at these kind of access to coverage as a top priority, and then thinking through what are the things under access to, like what are the principles under access to coverage?
Yeah, I was thinking that, you know, if it comes to each one of us, if we would agree, not just me saying do it, but if we would agree what those top items are that we want to deal with, you know, to initially get to. I mean, if we can do that, I think it would be helpful in how we move forward in accomplishing the goals that we want to get, you know, accomplished.
Okay, what do others think? Are there ones that everybody can agree to from the outset?
I agree. I have to say that the last 2 bullet points really speak to me, the expanding access and, oh, the last 2 on your page.
Oh, I'm sorry.
That expanding access for behavioral health service and strengthening our rural communities, just considering where I'm sitting and the point of view I usually have every day with the constituents here in my 2 counties. That's just really critical for us in public health to be able to do well.
So my number 1 would be the access to coverage. So I would just say that would be my number 1 before I picked anything else.
Would anybody else agree with that or disagree? Sounds like we have some. So Representative Cunningham, prioritize.
This is Dr. Newton. I can go along with that because I think that's basically what we've been tasked to do as a council, basically, and that sounds like what we are. There are other things here that are probably equally as important to me from my standpoint as a provider, that are basically down at the bottom or close to the bottom. I'm in a rural area, so obviously strengthening our rural communities is important to me, and also the workforce distribution. I'm the one that brought that up. And incentives and loan repayment type things, because I see that every day. My own practices have difficult. We're one of the premier practices in the state, independent practices, but we have a hard time recruiting. And so even if patients have access to coverage, you know, we see all types, but even if they have access to coverage, if there's no one here to see them, it doesn't make a whole lot of difference.
That's a great point. There's a pretty big difference, particularly in rural North Carolina, between access to coverage versus, I mean, what I would call in my world network adequacy, but what everybody else would call access to services. And so I think Tommy and Lisa's points are absolutely valid.
Well, and I did,
you know, sorry, go
reducing
ahead.
disparities was off the bottom of the page, so that definitely goes in there, top of public health issues too. Those three, and those go nicely together on what end up being really our community health priorities every time we do a community health assessment. Mental health, substance use disorder, reducing disparities, health equity, addressing vulnerable populations, and strengthening rural communities. Those things just come up for us all the time. And we have not found a good way to cover the cost of those things. And so even though I see them in a different category, like if we had a pyramid shape that sort of listed the base and then the top of the pyramid for these things, I mean, they're all critically important. They're all what we're supposed to be figuring out solutions for. But I agree with the group that prioritizing and then categorizing and then figuring out who does what and how we cover it is a nice way to attack the problem.
This is Representative Cunningham again. I wanted to come back. I know we worked on the CARES Act funding when it came in, and we did set some guiding principles in how we were going to distribute the funds for the state when it came in. And one of the things that we did, we used a set of guiding principles. We did, but we had to agree on those, guiding principles. But one of the things that we did is looked at what came first as immediate that we wanted to get done, and then second, our short term, and then our long term, so that we could move through and sort of focus on what has to happen first. So and I'm in Mecklenburg, but I actually am from Wadesboro, North Carolina, and I also frequently out in the rural areas, Stanley County and Cabarrus County. So one of the things for certain is that healthcare disparities has always existed in the rural areas since I was a child. In those rural areas, we already know that the lifespan is cut by 10 years than the people in the urban area. Most of that is probably due to education as well as accessibility and qualified healthcare providers in those spaces, because they can't maintain. People usually, they get their license and they usually move away, and trying to maintain them in the community has been a huge issue for years and years. But even in Mecklenburg County, we still have issues with people that don't have health care coverage, and they don't have, the money or the finances to take care of those services. So I was thinking, my thoughts is that in order to tackle rural, in order to tackle disparities across the state, not just in rural areas, because we have it here, because we have the crescent of poverty in Mecklenburg County. In order to tackle healthcare disparities and those issues, the first thing that my priority would be looking at the accessibility, who has healthcare, and also the other thing is, what does affordability look like? What does affordability really look like to someone in a rural area and someone in an urban area, or someone that has a top-notch insurance coverage and somebody that has a silver, or they have a bronze, or they don't have any? What does affordability look like based on economic income? Somebody making 13, 14, well, we know that's an issue, but somebody making 15, 25, that's a whole nother set. Somebody above, a whole nother set. What does it look like? I'm gonna stop talking.
This Chip, Representative Cunningham, I completely agree with you. I mean, having insurance is the golden ticket, right? I mean, that is, without that, people delay care, they avoid care, they wait till the last minute, they show up in the most expensive place possible to get care, which is at the emergency department, or they end up in the criminal justice system, or somewhere else where we're having to pay for it in an indirect way then. So I mean, I think you're right that we've got to attack the access piece. And in order to attack that, it's got to be affordable, because if it's not affordable, then we don't move the bubble on the access thing, and then everything else falls in behind that. Because if we don't have everybody with a golden ticket, then we can't reach them to have impact on their behavioral health or disparities or their chronic disease or any of those other things.
And speak up if I'm not capturing your comments correctly here too there. So I'm just copying what you were saying, Chip, around, you know, first step is access to coverage, but that if that coverage is not affordable, that doesn't accomplish anything.
Right, it doesn't, because nobody's going to, access is not going to increase if it's not affordable. If the coverage is not affordable. And I'm sorry, even with my glasses, I'm having a hard time reading the comment section.
Yes,
So
the comments.
I'm not tracking what all you're writing there.
Okay, apologies. Let's see. Is that any better?
That's a little better. Thank you.
Just trying to do it in comments to like keep everything on one page, but I think that you know, there's no perfect way, right? Okay, so priorities I'm hearing are access to coverage and affordability of coverage right now. And then, you know, Chip's point around some of these are effects like health system sustainability and supporting the business community. So they aren't bubbling up as high for folks at this point. Is that a fair?
And that may be because of the biases that we all bring in, right? We're all acknowledging that some of these things are the things that we ourselves suggested. Some of the things are the things that are most dominant in the worlds that we spend our 40-hour week in. So it's not that any of these are less or more important. It's just that we got to Representative Cunningham's original point. It's like, what do we have to do first? You know, if we don't do this.
Mm-hmm. So if I could drill in for a minute while we're on the, you know, we've said first priority should be access to coverage. Would everybody agree? With this second bullet under this bucket of a solution for North Carolina may include a combination of multiple coverage options?
I would agree with that.
And it could include any of the things that council's discussed, like Medicaid expansion, reinsurance, association health plans, extending coverage for pregnant women, enrollment in bronze plans, etc. Okay.
It's certainly not offensive, but it doesn't. It's not really bold either, is it?
Right. Okay.
It's a big tent concept, right?
Yes.
Right.
And it seems that might be the only way North Carolina gets to a compromise, as heels have been dug in for quite a while.
Anything you would add or change under, since this is a top priority, anything you would add or change under access to coverage?
I think what Chip was saying about the affordability of coverage is that could fall within that one category instead of separating it, because that's gonna have to align together, I believe. That's my thinking on it.
Yeah, thanks for saying that. I was just trying to figure out how to say that, because I don't want to devalue affordability by putting it as a sub-bullet, but it is integral, as you're saying, Dr. Representative Cunningham.
You're correct.
Yeah, and what Julia just taught us, it's definitely clear that just because something is accessible doesn't mean it's affordable. And we know that so much is true in behavioral health in particular. So I like that addition too. Thanks for that.
So for now, I'm just saying, I'm not drafting the principle per se, just saying that the concept of affordability could go under access to coverage as well.
I wasn't saying it that way. I'm gonna come back and say it again. Is I think it needs to go together. That's what I think. I think those two things have to come together in order to get what we need to get out of it. To reach the goal, it has to be both together. I'm sorry.
So you're saying they're both a priority one?
Yeah.
As opposed to one being a subset of the other?
Yes.
Okay.
I think they have to go together. Does that make sense?
Yes, ma'am.
So are you saying access to affordable coverage, or would sort of be the way of?
I'm saying that access to coverage and affordability of coverage needs to be together. Given access, and just because it may not be affordable, you're not going to get it, even though you have access. But you have to do both in order to catch a certain population. It has to be affordable and it has to be accessible, or else you're defeating yourself, because if it's not affordable, even though it's accessible, you're not going to get it.
Right.
So I'm saying it needs to go together, align it together. That makes sense.
It does, because I think when you put access to affordable coverage above, you lose the chance to define really what affordable is. And that's what we've got to, I think that's a really important thing to do for this group to do also, is because we've been, you know, Representative, I mean, we've been doing that, talking about what affordable is for 8 years now in the General Assembly, right? And it changes from year to year what is affordable. So getting some kind of standard that could be tracked over multiple years would be really helpful to kind of level setting the conversation there.
Okay. Is that fair? Proposal for the council is to define what affordability means. Okay.
Just a quick rider for affordability, and Tunde could probably, you know, talk circles around this topic. You can lower the cost of a premium however much you want and pass it on to the individual. And so what we really want is affordable and meaningful and quality coverage. I don't know if that needs to all be captured, but I think folks would agree with that. You don't want junk insurance.
Yeah, so a sub-bullet under affordability of coverage could be without sacrificing, affordability without sacrificing quality, I think you said, or meaning, or
Comprehensive. Yeah, there we go.
Yeah.
What's the word?
Thanks.
Healthcare coverage.
Great. So just as a time check, we have about 5 minutes. I think the discussion we're having is great, and we can keep going on these buckets. I just wanted to flag the time for you all. Other ideas around access or affordability, or if you want to spend some time thinking through these other pieces here, or if there's something that's not here that you think should be.
I'm gonna go up to the one, what is it, efficient, go back up to the money part. Let's see. Oh yeah, efficient use of taxpayer dollars. And I wanted to bring up, that's where telehealth comes in. It's very important that we expand on that. It's the telehealth, because an example is if you have a congestive heart patient and they're at home, and all of a sudden you have the nurse coming out and she's visiting, he's gained 5 pounds, and the nurse can weigh him, and they can electronically weigh if it's acceptable to our telehealth, whatever those standards or guidelines are. And if he's got weight on, she can call in and get the medication, give it to him, and he does not have to go to the hospital. We haven't quite gotten that far, but we need to look at our standards and our guidelines and moving forward for people that are able to stay at home. It's a more effective use of taxpayer dollars.
One thing that came up in our, oh, go ahead.
I was going to say, just along with that, that also brings in is everything's intertwined. I agree with you, Representative Cunningham. When you're in Sampson County, broadband access is one of the things that hinders that capability. Having used telehealth through COVID-19, no question I see the value of that. The problem is the access to access to telehealth from the patient's standpoint.
The network, I would say. And he's correct. I think that is something we're going to have to focus on moving forward because of the COVID, but because we're going to see a significant change in what we're going to be doing moving forward. And that broadband has definitely been an issue, and we've been working on it for years, but there's a whole lot more to be done.
So can I bring up something too that goes in another, I think that has a lot to do with the access and coverage of behavioral health services as well. My practice in particular is we're trying to work out the ability to use telehealth in our office to behavioral health providers, you know, because it's so scarce in our area for our patients. And, you know, so I think that has applicability there as well. And that would help expand the access to behavioral health services as well.
Yeah, you're talking about real-time
Yes.
behavioral health integration into your primary care.
Yes, yeah, really integrated care. Exactly. That you know, for when I need help with somebody that's you know, depressed or needs some you know, medication assistance, let's say, or just as for somebody that needs to instead of a face-to-face visit with a psychologist or a psychiatrist, be able to do that via telehealth in my office, so they don't have to travel to Fayetteville, Raleigh, Goldsboro, or somewhere to see somebody. They can do it in my office.
One thing that came up on the conversation today around the efficiently using taxpayer funds was the idea of maximizing our federal dollars and ensuring that the state is using state funds effectively. Are we in agreement about that concept and those ideas, or is there, thinking about that, anything that could be added to that? Oh, don't add mine. I'm asking the question, and I'm not a council member, so I don't want to.
I can chime in on that. That's definitely something that we need to be looking at, is how we can draw down the optimum level of federal funds. You know, we match, but we use a lot of federal funds to match other things, and we should definitely draw down as much as we can from the federal dollars that we pay in as a state and as individuals to, you know, take care of the people in the state. But yeah, and we need to look at if one alternative doesn't work up on the 115 waiver, we need to look at what is working in other places, what's available to us that can work, that we can draw down those dollars. We may not be able to draw it down one way, but looking at the other ways that other states are able to draw it down.
And I see that our time has elapsed at the bottom, so I suspect we'll be going back to the main group here in a minute. So any final thoughts that folks want to convey? And you can feel free, if you have something that occurs to you when we go back over, just put it in the chat, and we can do it that way too. Or bring it up during the discussion.
Thank you for coordinating.
Yeah, thank you.
Thank you.
Yeah, of course. Thanks for the great conversation.
Are we supposed to leave the room, or does that kick us out?
I think they will close it out automatically. I'm looking at our internal team, and it says 2 more minutes, but that was 2 minutes ago. So here we go. We're going back. Nice speaking with you all. Thanks a lot.
Thank you.